right. Good morning, Dr. Mandeville. Thank you so much for joining me for Conversations with Angela this morning. It is a pleasure to have you with me this morning.
I'm happy to be here. Happy to see you again. And
Yes,
thank you for allowing me to, I guess, talk about some of the things that I know and things that I've experienced and things that I have seen and things
yes,
that I hope will get better in the future.
yes, absolutely. So, can you tell us a little bit about yourself before we get started?
Yeah, well, my name is Dawn Mandeville, originally from New York, moved to Atlanta officially maybe in 1999. I have been a practicing OB-GYN since that time for over 25 years. I have a focus in complex OB-GYN, in minimally invasive and robotic surgery, and also menopause medicine. So, still quite busy, still love what I do, and most often. But no, I still love what I do, and I think we've talked in the past. Sometimes you're chosen for something, and that something continues to grab you and continues to push you forward. And taking care of women at all phases of life is one of those passions.
Absolutely. You're also a host of, what is it, Menopause and Mocktails.
Yes,
Yes, yes.
menopause and mocktails is another one of my babies, and it's come out of my evolution of maturing
Uh-huh.
and also taking one of my hobbies, which is cocktail making, and putting the two together and trying to teach women about the transitions that they're going to have into perimenopause and menopause and making it kind of fun with mocktails, not
Yeah.
cocktails, because cocktails will make us fall asleep.
Yeah.
So we do mocktails instead.
Mocktails would definitely make me fall asleep. Cocktails rather. I am such a
Mhm.
lightweight. Oh my God. Well, I would be asleep.
Me too.
So, we are here this morning to discuss the gross video that has gone viral for all the wrong reasons, with the white nurse and the way that she is treating the young Black patient who is obviously in distress, over the labor that she's experiencing. So, Dr. Mandeville, from your perspective, what should have been happening in that video?
Right. Seeing this very often, we see this all the time. A woman coming in active labor, uncomfortable, not able to articulate what's going on, but you're able to see that just based on her appearance. Family members nearby not knowing what to do, not really knowing what to say.
Mhm.
And what should have happened is the front desk should have alerted the triage team to say, "Hey, we've got an active patient here. She's coming in hot, basically." And we have hot rooms in our labor and delivery rooms that are empty for patients who come in active labor like that to be directly transported to those rooms to be delivered. So communication should have started. I've got somebody here who's in active labor. One nurse says, okay, tells the charge nurse, somebody goes open up the room, and they try to get that patient to that room as soon as possible. Sometimes there is a pit stop in the triage area, but that's up that you can kind of tell whether they need to stop to be evaluated or assessed before going to the room. So communication of somebody who's in active labor should have happened.
So I think I know the answer to this, but I'm going to ask anyway. Were any of those questions that the nurse was asking her necessary in order for her to get immediate care at that moment?
No, in my
Like,
opinion, no. It doesn't matter how many babies she's had. It doesn't matter who her doctor is. Well, it matters who her doctor is so that they know who to call.
mhm,
But um, the manner in which that nurse comported herself of as though it was a regular routine prenatal visit was
mhm.
not appropriate. It's as my kids say, read the room, mom, read the room.
Our kids
So
keep us
and
hip,
and
don't they?
yeah, and her complete disregard for the patient's pain,
Right, right.
lack of empathy. She couldn't give a hot, you know what,
Mm-hmm.
darn.
Mm-mm.
Um, that was the most. Not that the patient was in pain. Yes, she was
Yes.
in pain. That baby was coming. We know that. That's what
Mhm.
happens. But that nurse couldn't have cared less. She needed to do her job, and her job in her mind
Mm-hmm.
was to make sure that that computer screen was filled out with all of the information and demographics that she had to do. Darn the patient.
It was really
Um,
hard to watch.
it
It,
was really hard to watch
it was
because
really hard.
I could see her saying, "Okay, who are you? Who's your doctor?" as she's getting up and moving, and then turn her back.
Yeah, yes, she did.
Yeah.
She absolutely did.
So there was no inclination in her mind that she was going to help this woman before she got her work done.
You know, does it make you wonder, or have you heard of cases where Black women have been treated like this in situations when they had either other white nurses or other white doctors tending to them? Have you heard of this personally?
It's. I'm going to say yes. Can I take a specific instance?
Mm-hmm.
No, because it happens all the time, and sometimes it's not as overt as
Mm-hmm.
what you saw here.
Right.
Most often, nobody's videoing it, and nobody would believe that that's something that happened. Similar
Exactly.
to, police stops or incidents that may happen in the street. We have cell phones now.
Right.
Cell phones are acting as our documentation, our proof that we are being treated in a particular way, or proof that this is how it's happened. And
Mm-hmm.
it can't be your word against mine because it's there on video. So I
Yes.
think a lot of this happens, but it's not articulated. If this wasn't videoed and that family said, well, that nurse didn't care about us, people will say, okay, yeah, but everything's okay. The baby came out fine. Really? She really did that?
Mm-hmm.
It would just be it happened. Nobody
Mm-hmm.
else could put themselves in that place or imagine what actually happened. But now you can because it's there. It's
It's
on
right
video.
there. It's right there.
Yeah.
It's right there. And it really did something to me when you could hear, I think it was her grandmother who was with her, when her grandmother asked, do you treat all your patients like this or just the Black ones? That really struck a
But
chord with
but
me.
after she said that, did you look at the nurse? I want you to look at that video again and see what
Okay.
the nurse did or didn't do. She didn't budge. She didn't turn her head. She didn't flinch. She continued to get on the phone and give report. Didn't flinch. And I know she heard her.
Oh, yeah.
So it is the not only was she not listening to the patient, but she was completely ignoring anything else around her.
Yes.
Um, the grandmother's comment of, I told you you shouldn't come to this hospital. I told
Mm-hmm.
you, that added fuel to the fire. Grandma, come on. I
Mm-hmm.
need you to be helping. You don't add fuel to the fire. But honestly, it doesn't matter what hospital she went to.
Right.
It's not clear whether that might have happened in another hospital.
Right.
So
What does it say that she had the baby so soon after that happened? Obviously, we know that she was in active labor,
mhm.
but that obviously would put the mother and the baby at tremendous risk and the
Mhm.
hospital too. That she would have a baby, I think, what, 12 minutes, I think, after
Mhm.
that video was shot.
Mhm.
That means that they didn't have time to prep her. I mean, what did they
No,
do?
she probably got in the room and barely got her clothes off before she delivered. Probably didn't get an IV in. Generally, we try to have IV access in case anything happens where you can administer medications quickly. One of the biggest things is postpartum hemorrhage.
Mm-hmm.
This is her third baby. She's more at risk for bleeding after the delivery. Having IV access would help you get those medicines in to help you to stop bleeding. Being able to have the proper personnel there and ready to go instead of it being a crash and burn situation. It was going to be one of those in terms of getting her in the room and going, but she could have been in the room 10, 15 minutes earlier
Yeah.
so that the process, although be it urgent, was not emergent.
Mm-hmm. Exactly.
Somebody might have been able to place that IV. Somebody might have been able to get, and they could have gotten information from her support person.
Yes.
Mom or grandma knew that this is her third baby, that Dr. Lang was her doctor.
Right.
that she had been there earlier in the day, or no, that she was there for an induction and they pushed back the induction because it was too busy. This is what I've heard. This is not
Yeah.
facts. So,
Hmm.
um, this could have been handled differently. And, we, and on our labor floor, we have a lot of new and inexperienced nurses.
Hmm.
I can see that being a part of it. If this, I can't say how long this woman nurse was
Hmm.
in business, who had been in practice of nursing, but it doesn't seem like she's a brand new nurse.
No, it doesn't.
And I'm making an assumption.
Hmm.
So just given that lends pause, because how many other women does she do this to?
Hmm.
How many other times does somebody come, even if they're not in active labor, but they're
Hmm.
very uncomfortable?
Hmm.
How many other times has she said, I need to get my stuff done before I
Hmm.
let her get what she needs?
Exactly. I think that her actions prove obviously that she's not a new nurse, because I think that a new nurse would have been nervous, would have been trying to make sure that she got everything
Yeah,
done,
yeah.
didn't want this to
I
happen
need
on her
help.
watch. Yes, exactly. She would have been,
Mm-hmm,
trying to figure it out, and didn't want her to have the baby right there while
mm-hmm,
she's trying to ask her these questions. So I think it would have been quite the opposite. So I think that her actions prove that this is probably a pattern of behavior
mm-hmm,
for her. So, do you have any stats on what happens with Black women's maternal health? What are
mm-hmm,
some of the risks that women, well, obviously, we know that many women die after these types of things
mm-hmm,
happen. And we can see in that instance how that would be something that could clearly happen. I mean, because had she kept continued with that and the baby was just born right there in the room where she was asking her the questions, that could have been a real serious problem.
mm-hmm, mm-hmm,
I saw a video last night that said that the baby was born, obviously 12 minutes afterwards, and the baby was born with his eyes open and that his amniotic fluid was green. So
mm-hmm.
what does that mean?
So um, let me start with the last part. Baby was
Hmm.
born with his eyes open and the amniotic fluid was green. The baby probably had passed stool. And when the baby passes stool in the amniotic sac, it's called meconium
Hmm.
staining. Born with the eyes open, that does not
That's normal.
mean
Okay.
one thing one way or the other. Babies are
Hmm.
born with their eyes open or closed or cry or
Hmm.
don't cry.
Hmm.
Um, all of those things could have happened if she had a very calm and controlled delivery. So
Hmm.
that I don't think lends to anything negative.
Hmm.
Um, but in terms of what we call maternal morbidity, sickness, or
Hmm.
mortality, there are statistics that are kept. And what we have found over many years is that Black women, Black women, because I'm going to differentiate between just women of color,
Hmm.
that we are at least three times more likely to die within the first year after delivery. So delivery time and then within the first year. And it could be a number of things, whether it's hemorrhage, whether it's cardiomyopathy, cardiac, heart issues, stroke, blood pressure issues. There are many issues, and even they even put homicide, suicide in that statistical analysis as well. So Black women are at least three times. It used to be 3 to 4 times. I'm going to say 3 times. And
Hmm.
it doesn't matter what their socioeconomic status is. It doesn't matter what their educational status is. That statistic is maintained throughout all socioeconomic or educational lines, which is scary because you talk about, well, was the patient informed? Did she understand? Did she have access to care? When she had care, where did she go to get care? Was she living in an area where care was an hour away in those
Hmm.
obstetrical deserts or medical deserts? What were the circumstances surrounding? These are women who live in metropolitan cities with five hospitals within 10 miles of them,
Hmm.
who are still at risk, higher risk of dying around labor, delivery, and postpartum than their white counterparts.
Is there at least one underlying reason for that?
So we don't know for sure, but one of the ones that is discussed is systemic racism or systemic bias, where one is looked at, assumptions are made, and actions dictate what that assumption is. Can you take every example and say that this person treated that woman wrong? You can't, because sometimes it's so subtle. What I would say is let's take hypertension, for example. A woman comes in and she's having high blood pressure, and she's, let's say she's term, comes in and has terribly high blood pressure. We know that high blood pressure can lead to other complications: stroke, heart attack, cardiovascular issues, seizures. We know those things can happen. If one is looking at one woman versus another woman, the chances of a woman without color being treated faster are higher. There may not be a quickness in which somebody cares for that person, calls that doctor, emergently gets that medicine, that IV in, and gives her that medicine to bring that blood pressure down, to decrease her risk of having a stroke. Those are the little things. How long does it take? So with that, over the years, certain organizations have developed toolkits. And if I'm staying on the hypertension line, within a half an hour of an elevated blood pressure of a certain range, that patient should have gotten some medicine, no matter whether you can get her provider or not. There are things in place, protocols in place to be able to say, we know a bad thing can happen with this blood pressure, so let's treat it instead of waiting for the doctor to call back, because that's another step in care. That Miss So-and-so is here. She has high blood pressure. What do you want to do? If there's some sort of bias there, they may not say, I'll call you back. I'll be right there. Or, oh, Miss So-and-so, oh, give her this. So putting those toolkits or those protocols in place are trying to push bias out of the way so that you can treat the patient without even having a thought of who this patient is, what is her name, and what she looks like.
So, given that, what you said, are there any indicators that you think that women should be aware of or paying attention to when they're pregnant and they're going to their doctor's office on a regular basis and things are happening or not happening as they think maybe that they should? Is there anything in particular that they should be aware of that lets them know that, okay, maybe I might need to jump ship? And is there any danger in a woman changing her doctor in the middle of her pregnancy?
Those are really difficult questions. The jump ship question. So I think women are scared. They are scared. Black women are scared. I cannot tell you how many patients come in and can't make a decision because they're so afraid of what's going to happen. And they don't, it's almost to the point of paralysis sometimes, or it's to the point of mistrust. And that makes it harder to articulate what risks exist and what our concerns are because of the lack of trust. So it's hard for them to jump ship. It's easy if you're treated like that.
Yeah, exactly.
But that is an extreme example. Most others are relatively subtle. And most others, one might think, oh, that's a one-off, or not be able to process it enough to say, well, that was wrong, or process it and then internalize it and pray and hope that everything goes okay with the rest of the pregnancy and delivery. Jumping ship is hard because practices are not open arms to have new patients come in, because you don't know what's coming in.
Right.
And from the medical standpoint, we have to be very careful about not what we're inviting in, but we like to see our patients from early on in their prenatal care. So we know what we're dealing with. We can guide them. We can give them our opinion so that they are informed about what's going to happen throughout their pregnancy and hopefully in their labor and delivery and postpartum.
Mm-hmm.
If somebody's coming into the practice halfway through, it's hard to say, well, what happened
Right.
before and what do
Mm-hmm.
we have now? So a lot of practices don't accept patients later in their pregnancies
Mm-hmm.
for multiple reasons, but there must be sometimes there's a reason why
Right.
somebody jumped ship. We've heard it before. I just don't like my doctor.
Mm-hmm.
Okay. Or they're not treating me well.
Mm-hmm.
It's still hard to bring somebody in at 28, 30 weeks
Right.
because of that.
Right.
Um, because that's a whole nother set of issues. Is it the patient? Is it the practice? Is it where the practice is? Is it the staff? Is it the actual provider? Is that the provider that's going to attend the delivery?
Mm-hmm.
There's so many variables there.
Right.
I will tell you, when I said that patients uh, lack trust, I can't. We have so many patients on two sides. One where they will say, "Well, I want you, Dr. Mandeville," or we have several other women of color, or this person. That's who
Mm-hmm.
I want. When are you going to be on call?
Mm-hmm.
And I kind of take a deep breath, and I get it. I get. They
Mm-hmm.
don't even have to articulate it. Sometimes
Mm-hmm.
they do. I want you because you're black,
Mm-hmm.
and I say, I got you. I got you.
Mm-hmm.
But please know that I trust my partners and I trust my midwives, our partners, our midwives, and that if you're that uncomfortable, I need you to articulate. I don't want you to shrink
Mm-hmm.
back. And if you don't think you're capable, talk to your support person, your partner, whoever's going to be in there to have them advocate, because there's also implicit bias.
Yes.
So I don't want to say that we've got halos around us.
Mm-hmm.
There's implicit bias that happens every single day. When you know somebody's coming in the room and it's going to be a harder conversation, one, because either she has her shield up or because she presents herself as somebody who may not care, but she cares. She just doesn't know how to um, give that
Right.
information, that body information that she cares, or she's got a partner that's on his or her phone the whole time and sitting in the chair giving a vibe that they don't care. So if somebody
Mm-hmm.
gives that vibe that they don't care, well, why are you going to care so much? Are you going to spend as much time as somebody who's asking you a lot of questions? Or are you
Right.
going to say over and over again, do you have questions for me? Partner, do you have questions for me? Partner,
Mm-hmm.
are you on that phone again? Put that
Mm-hmm.
phone down.
Mm-hmm.
There's a way to do it. And
Right.
and there are times where I'll come in a room and say, okay, come on, don't make that assumption. She's pregnant, 33 weeks, just like this other woman is pregnant,
Mm-hmm.
who doesn't look like her. You have to comport yourself the same way for both. You have to give them the same information.
Right.
And whatever you receive back, you have to use that to still help get that information to that patient.
Mm-hmm.
If it looks like she doesn't understand, you have to then take it a different way.
Right.
So that's hard because in a busy day, you're trying to get in and out of a room. You're trying to do but sometimes you have to stop and say, okay, she's 23 years old. This may be her third baby.
Right.
She's coming in from work, had just come in from work, or and I'm going to use it.
Mm-hmm.
The partner's there, but the room smells like weed.
Mm-hmm. Oh my
Um, she does not seem as interested as she should. There's a lot. So based on that, and there's many patients that come in with
God.
just that scenario.
Wow.
Why should I give a damn if
Mhm.
you seem like you don't give a damn?
Right. Exactly. Mm-hmm.
And if you think about it, you have to give a damn even if they don't think so. And if you have a provider, and this is being recorded, so off camera, I'll let you know something. But
Okay.
some providers may say, well, okay, tummy check, baby's fine. You don't give a damn, I don't give a damn. You're fine.
Mm-hmm.
Bye-bye. See you in 2 weeks. So implicit bias is real, and we have
Yeah.
to really call that out almost on a daily basis, because sometimes you'll do that and you'll think about it and say, ooh, I could have done that differently. Or
Mhm.
they made me so angry. Why should I? Well,
Yeah.
because that's your job. That's what you're here for, to guide them. No matter if they call you names, you still have to take care of them, and you've got to take great care of them. Did I
That's
answer that
so
question?
You did. You did. I don't think I realized how difficult it was,
Mm-hmm.
from a doctor's perspective. I mean, I know all the work and training and things that you have to
Mm-hmm.
do to go through to be a doctor, but just on the daily, like what you were just describing,
Mm-hmm.
I don't think I ever thought about it from that perspective, that you might have a patient that's coming to you for care, but they're acting like they don't care. So you're like, well,
Mm-hmm.
if you don't care, why should I care? If you're not paying attention or doing the right things or whatever, then why should I, spending all my time? I could be visiting another patient who does care.
Mm-hmm.
So I guess there are just a lot of variables that go along with it.
Mm-hmm.
But for those patients who do care, and are seeking, decent treatment from a
Mm-hmm.
doctor,
Mm-hmm.
they're not expecting to get what they got from that nurse,
Not at all. Not at all. And I
ever.
think the expectations, a lot of patients don't know what the expectation is.
Hmm.
They don't know that that scenario is going to present itself. And obviously, she really couldn't advocate for herself, other than when the woman said, "When is your due date?" She said, "Now."
Yes, exactly.
And then she asked it again, and the woman wanted a date.
Hmm.
To me, read the room. You don't need a
Yes.
date. It's
Yeah.
happening. So
It's
whether she's
right now.
preterm, post-term, it's happening. One other thing about what happens in the room when we're seeing a patient, in not only in the antepartum, not only prenatal care, but postpartum. Sometimes I'll have to say, "Hey," I said, "What's this?" And I go like this, "What's this? Your
Hmm.
hand? Mm, what's this?" I
Hmm.
said, "What color is this?" And they'll stop, and
Hmm.
I'll say, "What color are you?" And they stop. I said, "I'm not telling you this because I'm badgering you. I'm not telling
Hmm.
you this because I want to scare you.
Hmm.
I'm telling you this because this is real. And
Hmm.
you have a 3 times more likelihood of dying in this process. So I'm not blowing smoke.
Hmm.
I want you to make it out of this as much as you do. I want you and your baby to be safe." So sometimes they stop playing around. Stop with the I don't want to do that, or I don't feel like I need to do that. You guys are making me come back over and over again. Why do I have to get my blood drawn? Why do I have to go to the hospital?
Hmm.
Because you're black, and
Hmm.
because you have a higher chance of dying. And
Right.
sometimes I'll have to say it like that. And most often it they pause. And then some women come in knowing that and are so scared that they just can't focus. They cannot focus, and I've had women trembling, so scared about what's going to happen during her delivery.
Yeah.
So
I know. I just want to let everyone know that you delivered my twins 24 years ago. And I was an extremely high risk pregnancy. And I had to do a lot of extra things. I had to go to the doctor twice a week. There were just so many things that I had to
mm-hmm.
do because, my pregnancy was high risk. But I think I just made up my mind early on that I just could not afford to sit at home and worry about it every day. All I was going to do was whatever I was told to do. If you told me to come 3 times a week, I would have come 3 times a week. So whatever I was told to do, that's what I was going to do. But I was refusing to sit at home and just worry myself every day about what could happen because I knew that there were a lot of things that could happen. So I would have been one of those patients that it would not have been a good idea
Mm-hmm.
to jump ship because there were so many underlying factors,
Yeah.
with my pregnancy. So I can't
Yes.
imagine someone like me, having a bad experience during their pregnancy and deciding that they want to switch providers and go to another doctor, in the middle of a pregnancy like that. That just adds more fuel to the fire.
Right.
So
And you don't go ahead.
I was just going to say that I think that the underlying message here is that we do have to be advocates for ourselves. And if we can't, then we need to bring one with us, somebody that can speak on your behalf and someone that can be there for you to speak on your behalf, like the girl brought her grandmother with her,
Mm-hmm.
but you do have to have someone with you, especially when you're in situations like that. I spoke with one of my doctor friends yesterday, and he works at a sister hospital to that hospital in Dallas.
Mm.
And I was asking him, had he seen the video? And he was like, yeah, I saw it. And he said, but it's really not surprising. He said, I really hate to say this, but Texas ranks like right at the bottom in terms of healthcare and how, we treat patients. He says, so it's really not surprising for Texas because that's just how Texas is. They don't have a good record for how they treat their patients
Yeah.
on record.
Yeah. Which is terrible because if you
Is
know it
is
and you're
really bad.
articulating that, that's just, but that's kind of like, this is what it is, which
Exactly.
is part of the problem.
He said it. That's pretty much how Texas is. Well, I know that you have a tea time coming up, that golf is your favorite thing to do, and that you are going to do it. It looks like it's shaping up to be just a beautiful day in Atlanta to do that.
Yeah.
So I want you to go and have yourself a great time. Thank you so much for this conversation. I just wanted to get this out and just wanted to have this
Mm-hmm.
conversation about this because this is a really hot topic. But like I said, it's for all of the wrong reasons. But it's still something that we, as Black women need to know and need to talk about and need to talk more about.
Right.
So thank you so much for sharing with me today.
You're welcome. I have one other thing.
What's that? Okay.
Just the advocate part of this,
Yes.
um, having somebody there with you to ask questions does give the provider pause to say, well, let me think about that. So
Mm-hmm.
that I think is hugely important, because when you have somebody there that has some sort of a bias, you're either going to have delayed care, or you're going to have poor care, or not get care at all. So
Mm-hmm.
having somebody there as an advocate, advocating for you and bringing those things to light, slows things down a little bit in terms of that person thinking, and speeds things up in terms of care and adequate care. I'm done.
Thank you so much, Dr. Vanderbilt. It has
You're
been an
welcome.
absolute pleasure to speak to you this morning.
And
Thank you
and
so much
wonderful
for
to speak to
sharing.
you as well. Good to see
Oh,
you, and I hope the women are doing well.
they are doing just fine. I will tell them that you asked about them.
Please, please, please.
All
Okay.
right. Thank you so much.
Have a great day.
All
Bye
right.
bye.